All right, good evening, everyone. It's 5 o'clock, so we'll go ahead and get started with our next installment of the ASRA Journal Club and Roundtable. I'd like to introduce myself. My name is Keith May. I'm one of the co-organizers, along with Dr. Brian Schran, and just wanted to welcome everyone to tonight's session. Before we dive in, just a few quick notes. CME credit is available for tonight's session. There will be a link that will be listed in the chat. So if you'd like to claim your free CME credit, please follow that link. Regarding the format tonight, our goal is to not only review the literature, but also to have some robust discussion on kind of what we do clinically in different parts of the country and different clinical practices. Um, Let's see. Finally, if anyone has any interest in presenting or moderating at a future journal club, please contact me. I'll add my email into the chat below as well. So now it's my privilege to introduce our moderator, Dr. Mark Beckerman. Dr. Beckerman is an assistant professor at the Mount Sinai Anesthesiology Department in New York. After his residency training at Rutgers, he completed his regional anesthesia fellowship at Mount Sinai and subsequently joined the faculty. He's deeply involved with academic leadership. He serves as the Associate Program Director of the Regional Anesthesia Fellowship and as a Junior Faculty Development Advisor. His commitment to education was recently recognized when he was named Mount Sinai's Faculty Educator of the Year. Tonight, he's going to be leading a discussion on Phrenic-Sparing regional anesthesia techniques for shoulder surgery. We'll be reviewing recent evidence on approaches that balance effective pain control with the preservation of diaphragmatic function. This is definitely a very clinically relevant situation for many of our patients that have pulmonary issues. So Dr. Beckerman, thank you for being here, and I'll turn it over to you.
Excellent. Thanks for the intro, Keith. Thanks for having us, everyone. We're joined today by our wonderful two fellows, Stephen and Ragad. So our talk is entitled Breathing Room, Phrenic-Sparing Strategies for Shoulder Surgery. Next slide, fellas. All right. So we have a few learning objectives for the day. They are to compare the analgesic efficacy and incidence of hemidiaphragmatic paresis among contemporary phrenic-sparing approaches for shoulder surgery relative to traditional interscaling block. Interpret the key findings and limitations of recent evidence on phrenic-sparing shoulder blocks, including systematic review, meta-analysis, and RCT data, to evaluate whether modifying interscaling block technique, including extrafascial injection and reduced local anesthetic volume, meaningfully decreases respiratory impairment without impacting block quality and duration. And finally, to apply some current evidence to select an appropriate regional anesthetic strategy for shoulder surgery in patients with poor pulmonary reserve versus those at an elevated respiratory risk. So just briefly to start here, right? We know that multimodal pain regimens, including regional nerve blocks, are recommended for shoulder surgeries. So these days, right, almost every type of specific surgery at most major academic medical centers has, right, an ERAS protocol, enhanced recovery after surgery. And at least where we practice, and I'm sure where many of you practice, something such as an interscaling block might be pivotal to that, particular multimodal regimen. The interscaling brachial plexus block is oftentimes the first choice technique, despite a high risk of unilateral phrenic nerve palsy and hemidiaphragmatic paralysis. So, as we'll get into talking about over the course of this discussion, we know that interscaling block often is reported as having a 100% chance of unilateral hemidiaphragmatic paresis, which can become extremely challenging for some population or subset of our patients. So patients who have obesity, COPD, and other pulmonary pathologies, perhaps we need to start thinking about a little bit differently. And coincidentally or not, Steve and I were involved in a block yesterday. The patient was a little bit on the bigger side, but reportedly only had OSA. So we were just watching another regional attending perform superior trunk block, thinking that that alone would be sufficient in terms of keeping her respiratory status on points. But unfortunately, she definitely suffered from this particular choice of block and ended up needing to go on BiPAP and stay an extra night in the hospital. So all things that we're trying to avoid. So maybe with hindsight being 2020 and us going through a talk such as this, we would have chosen an ulterior option. So, Stephen, why don't you take it from here?
All right, so the first article we'll be reviewing today is entitled Hemidiaphragmatic Paralysis After Ultrasound Guided Brachial Plexus Blocks for Shoulder Surgery. It's a systematic review and meta-analysis of randomized clinical trials, published in June 2025 in the Journal of Clinical Anesthesia. It looks specifically at the incidence of hemidiaphragmatic paralysis after various ultrasound-guided brachial plexus blocks and interventions. To try and reduce that paralysis. Researchers, over the past number of years have proposed several different modifications to try to reduce phrenic nerve blockade. These include using low volumes of local anesthetic, usually less than 10 milliliters, extrafascial injections, usually positioned at least 4 millimeters lateral to the plexus, lowering the concentration of local anesthetic, usually less than 0.2%. And then also alternative blocks. These include things like superior trunk blocks, infraclavicular, costoclavicular, brachial plexus blocks, anterior and posterior suprascapular blocks. Some studies have looked at these various blocks in isolation or in combination. And so, again, this study was really trying to look at all the reviews in literature and try to form a little bit of a conclusion. So, study objective, was to compare which regional anesthetic modifications helps best prevent hemodiaphragmatic paralysis after shoulder surgery. There were two hypotheses they were studying, whether one, alternative blocks are as effective at preventing hemodiaphragmatic paralysis as ultrasound-guided conventional interscaling block, and whether we can help ensure adequate post-op pain is maintained while sparing the diaphragm. So this study followed PRISMA guidelines and Cochrane methodology. They included about 28 randomized clinical trials with over 1,700 subjects. All studies that they looked at were from prior to 2022. They used studies that had control groups, which was defined as a conventional interscalable block using more than 15 mLs of local anesthetic. Primary outcome measured was complete hemodiaphragmatic paralysis, defined as reduction in diaphragmatic excursion more than 75%, which they measured using ultrasound. And so here's sort of just the framework of how they went about finding these RCTs. They went over hundreds. They screened them. They had two researchers going through them manually, excluding various reports if they didn't have control groups or such. In the end, they found 28, appropriate RCTs. They ended up using 22 in the actual analysis. Some were, again, excluded because they lacked a accompanying control group. About 1,737 subjects. They use something called the grade approach to classify the certainty of evidence. And you can see that on the right side of the, I don't know if you can see my mouse, but on the right side of the graph, the grade certainty of evidence is divided into 4 levels: high, moderate, low, very low, based on confidence that the true effect lies close to the estimated effect. It evaluates evidence quality for guidelines, systematic reviews, starting with study design, adjusting based on the risk of bias, consistency, directness, precision, and publication bias. So one of the first, modifications they examined were low volume interscalene blocks. So usually using less than 10 mLs of local anesthetic for the interscalene block. They found that overall there was about a 38% reduction in hemodiaphragmatic incidence. P-value of about 0.02. However, they found that the grade score was relatively low for this intervention. Next, they looked at extrafascial interscalene blocks, so more than 4 millimeters away from the plexus. In this case, they found significantly lower incidence of hemodiaphragmatic paralysis, a very low p-value, and a very high grade of evidence showing that it is effective. Next was superior trunk block. Although the meta-analysis achieved statistical significance, trial sequential analysis indicated that the superior trunk block showed a non-significant lower incidence of short-term follow-up, incidence of hemodiaphragmatic paralysis. They noted that this sort of block will require further evidence to see if it really is effective. Then they looked at the supraclavicular block. They found about a 46% reduction. However, again, a low grade score for evidence. Next was the combined infraclavicular suprascapular. And this one is sort of what really stood out in that there was a 97% reduction in hemodiaphragmatic paralysis incidence. They actually found that there was no subject that experienced the paralysis after this approach. And it had a moderate grade of evidence. So definitely something to consider moving forward. So just additional ideas to keep in mind for analgesia, except for the NRS score following the low volume technique. There was no statistically significant difference in analgesia-related outcomes in any of the 6 comparisons, so regarding pain. And then there are also complications. For each comparison, the incidences of Horner syndromes, hoarseness, and dyspnea observed in the intervention arm were lower than those following conventional interscaling blocks. So I think the key takeaway is that these diaphragm-sparing techniques generally preserve analgesic efficacy while offering a generally safer respiratory profile. The trade-off between respiratory safety and analgesic still remains an avenue of clinical consideration. So here we really just have a review. Again, going over the reduction of diaphragmatic paralysis. Really across over nearly 1,500 subjects, these techniques provided an overall 65% reduction in paralysis. However, there's this dilemma that as we move away from the interscaling space, what we call distal techniques, respiratory safety improves, but we do risk, insufficient analgesic coverage of the shoulder. So depending on the type of surgery, you really do need to balance these 2 considerations. So some more findings. Again, distally, I think we're safer and have lower risk of diaphragmatic paralysis. Superior trunk block, we are seeing lower incidences of Horner syndrome. Extrafascial interscaling blocks, we have less hoarseness. Low volume, we have reduced dyspnea. We do tend to still see these complications with supraclavicular blocks, probably because they are near the nerve roots and trunks. And again, we are at risk of developing these complications. So some strengths and limitations of this study. So for the first part, it is one of the first quantitative review evaluating novel diaphragm-sparing strategies using hemodiaphragmatic paralysis as a primary outcome. They only use randomized clinical trials to strengthen the evidence level, and they use ultrasound guidance to localize the nerve and enhance generalizability. Some limitations. Some of the data was limited for the comparisons, increasing the risk of detecting a treatment affected by chance alone. Findings were confined to hemodiaphragmatic paralysis in the immediate 24-hour post-op period, and no safety-related or functional outcomes beyond the 24-hour follow-up period was assessed. And now we're just sort of looking at that, even though we were looking at all these interventions, we did have various degrees of evidence to see whether or not they were effective. We had high evidence for the extrafascial group, moderate evidence for the low concentration interscaling block, and low evidence for the efficacy from supraclavicular blocks. Overall, these techniques are less likely to cause hemodiaphragmatic paralysis compared to conventional interscaling blocks. And I think it's important to continue assessing these techniques to assess their safety and efficacy, and make sure that we're providing the best care for our patients. I'm just wondering, at your institutions, how do you guys try to help reduce the incidence of hemodiaphragmatic paralysis? If anybody would like to share.
This is Jen Anderson. I'm a regional fellow at UNC, and one of our attendings, Dr. Monica Nanda, actually has a study going right now at our ambulatory surgery center comparing interscalene blocks for shoulder surgery with infraclavicular and suprascapular nerve blocks. So we're kind of actively collecting data on that technique. So it was neat to see in your review that technique is, the infraclav with suprascapular is at least currently thought to be the most effective at reducing diaphragmatic paralysis. And I think that's what Dr. Nanda is seeing currently with good outcomes in analgesia. And the suprascapular block, the distal one, is actually really easy to perform. So that's an upside as well.
Thanks for sharing, Jen. I think that's particularly interesting, and I think most of us would agree that suprascapular combined with either infraclav or axar is probably going to be the best approach going forward. And then in general, right, I think the reason why this stuff is particularly interesting is that perhaps of all the blocks we do for analgesia for all of our patients, interscaling is the one which potentially has the most possible deleterious effects, right? So we really do need to weigh the benefit versus risks of performing these blocks. Is it really worth it to do on some of the particularly sick patients? Or perhaps they have, some type of chronic, pain or opioid history, then we think that it would truly benefit them and that we should go through all these different ramifications and all these different possible varieties of block in order to provide them the best analgesia possible. I do often, when we're teaching the residents, like to point out, some people might say that if this patient has, hemodiaphoretic paresis and subsequent drop in their O2 sats, some people might be inclined to say that, that was a complication of the block, right? But we like to point out that, right, it's more of a side effect. So, meaning this is an expected outcome, and it's something that we need to be able to either, expect or manage and subsequently deal with. So, the fact that we have all these different blocks potentially at our disposal and potentially the ability to kind of rank them in terms of, the least likely chance of causing a bad outcome for our patient is extremely important. So with that in mind, maybe we'll kick it off to the second paper here that Ragad is going to talk about, which is kind of a specific aspect of kind of one of the things mentioned in the first study.
Yes. So now for the second article, respiratory impact of local anesthetic volume after interscalene brachial plexus block with extrafascial injection. And this article is a randomized control clinical trial that was done at Lausanne University Hospital in Switzerland. The authors of this article already proved that 20 mL of local anesthetic injected a few millimeters lateral to the brachial plexus will provide effective pain control during and after the surgery, shoulder surgery, and will give a similar analgesic efficacy to the intrafascial conventional interscalene injection, with also a 70% reduction in hemidiaphragmatic paralysis at 30 minutes and a 25% reduction at 24 hours. So they wanted to further test this extrafascial injection with reduced volume. So they used volume of 10 mLs rather than 20 mLs during this RCT with an extrafascial approach to see if it will additionally reduce the rate of hemidiaphragmatic paralysis while providing a similar analgesia. So they recruited adults between 18 and 85 years old, undergoing an elective shoulder surgery between April 2021 and September 2023. This was a randomized controlled clinical trial. Randomization was done using a computer-generated randomization and sealed opaque envelopes. They had two groups. The first group is the control group, where they used 20 mL of ropivacaine, 0.75%. And for the experimental group, it's the same ropivacaine, 0.75%, but with a reduced volume, 10 mL volume. For the exclusion criteria, any pre-existing upper limb neurological deficit, prior neck surgery or radiotherapy, moderate or severe pulmonary disease, and chest deformity and pregnancy. Now, for the procedure, they did the interscalene block before surgery using a 22 gauge 50 millimeters needle under ultrasound guidance, and they injected and using an in-plane lateral approach through the middle scalene muscle, and they injected the local anesthetic 2 to 4 millimeters lateral to the brachial plexus sheath between C5 and C6. The spread toward the phrenic nerve was not intentionally avoided, and the needle was not repositioned unless the patient was complaining of paresthesia. All the cases were done under general anesthesia with usage of multimodal analgesia using dexamethasone, ketorolac, paracetamol, and Zofran. For post-op pain, they used morphine 1 to 2 milligrams IV Q10 minutes, PRN in PACU if the pain score was more than 4. And all patients received a scheduled paracetamol and ibuprofen in addition to a morphine PCA for breakthrough pain. The block was assessed every 5 minutes before the surgery, and sensory and motor assessment were done, and a successful block was done when a complete sensory and a motor block was achieved in both C5 and C6 distributions. For the primary outcome, they set the primary outcome as the rate of hemidiaphragmatic paralysis at 30 minutes. And this was assessed using ultrasound probe in supine position and M mode. And they also looked at a bedside spirometry. The sample size required for statistical significance was 48 participants, 24 in each group. But the target was to recruit 60 patients to allow for 25% dropout rate. And the statistical analysis was done using the intention to treat analysis, and P was set less than 0.05 for significance. So 60 patients were randomized, 55 completed the study, and 27 in the control group and 28 in the low group analysis. These are the baseline data and the characteristics of the patients recruited. And all 55 participants achieved the primary outcome and had a successful block at 30 minutes. There was a 61% absolute reduction in hemidiaphragmatic paralysis at 30 minutes with a P less than 0.001. And all participants with hemidiaphragmatic paralysis had fully recovered at 24 hours after the surgery. Now for the secondary outcomes, there were no differences in respiratory related outcomes between groups during the study. And the low volume group had a longer onset time for sensory and motor blocks and a shorter durations of the sensory and motor blocks. So there was a 80% 80% hemidiaphragmatic paralysis at 30 minutes in the standard 20 mLs group versus only 19 in the low volume group. But the duration of analgesia was shorter in 5 hours shorter with the low volume group, and the 24 hours morphine consumption was 8 milligrams higher in the low volume group. So reducing the volume from 20 to 10 mLs with an extrafascial approach reduced the rate of hemidiaphragmatic paralysis by 60%, but it also did not impact anything on the respiratory function.
I don't understand.
And this reduction in volume also did a reduction in the overall analgesia time for the block, and an increase in IV morphine consumption at 24 hours by 8 milligrams. And these differences were clinically relevant, and the shorter duration of analgesia was expected because the analgesia is directly related to the total mass of local anesthetic. And anesthesiologists can't predict which patients will develop hemidiaphragmatic paralysis, even with this low volume extrafascial injection. So for patients with higher grade of dyspnea, obesity, or pre-existing respiratory disease, the physician should assess and discuss the risks and benefits of the block, and keeping in mind that without an interscalene block, higher systemic opioid requirements will lead to sedation, respiratory depression, and hypoxemia. So in conclusion, a low volume of local anesthetic injected extrafascially will reduce the rate of hemidiaphragmatic paralysis, but without any impact on respiratory function. With a trade-off of an increased onset time of the block, reduced duration of analgesia by more than 5 hours, and a higher morphine consumption. So the authors came to a recommendation of injecting 20 mLs of local anesthetic lateral to the brachial plexus to be the most reasonable approach when balancing risks and benefits.
All right, so kind of like let's bringing everything together now. The way I like to look at this, I was, curious if we were in a room full of anesthesiologists, and half of us knew proper regional anesthesia and the rest of us did not, but you had a similar patient in terms of needing to provide shoulder analgesia. I think kind of a take-home message here might be that the first article would kind of be, as the regional people, that would be the article that I would lean into, knowing the different variety of different possible shoulder blocks, and being able to kind of triage the particular patient and potentially ending up on an option like a suprascapular or infraclavicular block. Whereas if you just have your generalist that also needs to provide shoulder analgesia, perhaps the take-home point from the second article might be a little bit more up their alley. They don't necessarily need to learn an entirely new block, and they could have a decently, decreased chance of having hemidiaphragmatic paresis by just potentially injecting less volume. So if you were to bring this information back to your institution, and someone who without this level of training that most of the people in this chat have, maybe would just make the, second recommendation to them. Another option, which I don't think was necessarily talked about, we didn't talk about today, some people have said, obviously, why don't you just put in a catheter, and maybe instead of giving the full volume, which we would normally give for something like an interscalene block or superior trunk, just let the slow rate of an infusion kind of bathe over the tissues as well, bathe over the nerves. And oftentimes these patients don't have that same profound effect from low volume over a long period of time. So with that in mind, I just kind of wanted to open this up to the room. We always ask the same thing when we end every one of our in-house journal clubs, which is, with all the things that we've discussed today, would this end up changing anyone's practice? And if anyone has any, existing ideas about, the best way to manage these types of patients that you guys might come across.
if you're using general anesthesia in association with a block, number one, the initial paralysis of one diaphragm is not that important because you're ventilating the patient. But if you use as you said, a catheter, and you initiate your block with something like lidocaine or mepivacaine, which only has an hour or 2 hours of duration, put a catheter in and run 0.2% ropivacaine for analgesia, you really avoid the problem of the hemi diaphragm.
I have a question.
Yeah.
Yes, Zulfikar Ahmed from Wayne State University, Trinity Health. Is there any known, even case reports of severe complications with the hemidiaphragm paralysis in literature?
What do you mean by that?
Yeah, actually at ASRA this year, there was a case study of a patient that developed yeah, I'm not sure if it was just atelectasis or of the lung as a result of the hemodiaphragmatic paralysis. And the patient had to go to ICU, and they had to basically wait for the block to wear off.
I think even in unanticipated admission could even be kind of considered a complication, right? We're making this patient stay an extra night in a hospital that wasn't originally intended, and all of the sequelae which comes from any patient in particular being in the hospital, things we know about communicable diseases and the patient's not recovering as well just for the extra time being in house. So even something as simple as that, which is hopefully avoidable, could be something to, keep in mind.
Yeah, I agree. Unplanned readmission, admission is certainly a very important factor to consider.
This is Jen Anderson again from UNC. Just this past week, I learned of a patient who underwent a supraclavicular block at our ambulatory surgery center and sustained hemidiaphragmatic paralysis as a result. And this was a patient who had no baseline respiratory impairment. But the hemidiaphragmatic paralysis presented when he was an ambulatory patient. He went home and then had just, subjective dyspnea, went to the ED, and on ultrasound did have reduced diaphragmatic excursion. He was still satting appropriately, was able to be discharged home. But I think it just highlights how diaphragmatic paralysis, even if it's not causing clinically significant respiratory impairment from a sense of like how are they oxygenating and ventilating, just the subjective component can be really uncomfortable for patients and cause distress. And especially when we're using long-acting agents, like if we're using liposomal bupivacaine and, maybe they are stuck with that sensation for 3 days, that's a pretty big deal. And this was, super clav block, so lower risk of the outcome, but it's in some sense binary. If you have diaphragmatic paralysis, you have it. And so it didn't really matter that it was, quote unquote, just a super clav. So just would put that thought out there that the patient's subjective experience matters as well. And who knows how much his copay was for the ED visit, and then the resource utilization of the ED visit as well for the hospital system.
Thanks. Yeah, that's a great point, and definitely something we should have mentioned, right? If there's any students in this chat here, but essentially, right, anytime you knock out half the diaphragm, you don't necessarily knock out 50% of lung function, right, because of your accessory muscles and things like that. But you often do decrease FEV by 20 to 30%. But like you're saying, right, patients might often have the subjective sensation of shortness of breath, but then if you look up at the pulse ox in your normal standard patient, they're still going to be satting very high 90s. So only in this particular population, maybe someone like even the unanticipated, like you had mentioned with the superclav or the patient that I mentioned at the intro talk, is this something that we really need to consider? If that's it, thanks everyone once again for joining. Appreciate your attention.